All right, up next, Kate Ackerman, Associate Professor of Medicine at Harvard Medical School, founder and director of the Tsai Female Athlete Program at Boston Children's. Kate's going to talk to us about updated screening and prevention of relative energy deficiency in sport. Kate?
So I'm going to surprise my Leadership Council colleagues, and I'm going to be under 10 minutes. They all know I have the gift for the gab, but I really want to acknowledge my co-presenters and give them some time to answer questions. So you're welcome, Scott. Okay. So one of the topics I'm going to talk about, or the topic, is relative energy deficiency in sport. And those of you who know me know that I'm a huge feminist. So why am I not talking about a different topic? Because this actually affects women and men. But relative energy deficiency is something that is very common in our female athletes. And so for the last couple of years, we've really spent a lot of time doing a deep dive trying to improve the science behind REDS, as well as improve the screening tools that we have. So this concept, relative energy deficiency in sport, or REDS, was introduced in 2014, and I want to acknowledge Dr. Margot Montjoy, who's on our advisory council for WUSI, Human Performance Alliance. And so basically the IOC, the International Olympic Committee, was asked to update their female athlete triad position statement. So many of us know the female athlete triad is this concept of low energy availability, menstrual dysfunction, and poor bone health. A lot of great research is there behind that topic. But the IOC said, you know, we see low energy availability happening in women and in men, and we see other health and performance consequences. So we see that there are effects on other parts of the endocrine system, my favorite system. So thyroid abnormalities. We see changes in metabolism, hematologic system, so iron deficiency. We know that athletes who are really restricting food really affect their growth and development. Also psychological input. So psychological things can have an effect and they can be a consequence. Cardiovascular system in terms of vasodilation, and the GI system. How many of us who are clinicians have seen female athletes or male athletes who have some GI distress that go along with their low energy availability? And then of course, the part that really, really drives it home to our patients is all the performance issues. So if I'm talking to a young athlete who's competing and I say, oh, you got a stress fracture and we need to be concerned about your low energy availability and your menstrual health, they might just say, well, I'm going to get over my stress fracture and get back to work. But if we start talking about other performance effects, the fact that they are training really hard but not seeing the gains that they want, then they start to pay attention. So in the last couple years, we've been working on this topic, and one of the first things is, what is this energy availability? So we know it's dietary energy intake, subtracting exercise energy expenditure, and then normalizing it to fat-free mass. This whole concept really came about from some of the great work that Ann Laux did years ago on habitually sedentary women, where she could really control the environment in terms of what they ate and what they exerted in terms of their exercise. And she found all sorts of changes in hormones. She found decreases in LH. She found changes in LH pulsatility. She found changes in bone turnover markers. All of these things happened very, very quickly over the course of a few days. And so initially, the number that she came up with was 30 kilocalories per kg of fat-free mass per day was this magic number. We all need to be achieving that. Well, over time, we've realized that might not be the magic number for everybody. But a lot of people aren't even hitting that. So if you have a female athlete and she eats 2,000 calories a day, she goes for a 600 kilocal run, and she has 51 kilograms of fat-free mass, she's only getting 27.5. And it turns out some of our adolescent athletes actually need more like 45. And there's individual variation. So what's the prevalence of REDS in girls and women? Well, it depends how you measure it, somewhere between 23 to 79.5%. That is quite the span. So we need to figure out how to study this better. We need to really pay attention to which populations we're looking at. Are we talking about gymnasts? Are we talking about ballerinas? Are we talking about basketball players? Is it done by a survey? Is it being done with hormonal markers? So that's some of the work that we've been trying to do. So there's going to be an upcoming edition in the British Journal of Sports Medicine where we have about 10 papers if we're lucky and they accept them all. And the idea is it's a special IOC edition. And here we are in Lausanne. That statue is from Pierre de Coubertin, who is the founder of the modern Olympics. He was not a big fan of females doing sports, but we'll move beyond that. So this is us. We're all working over there in Lausanne working on these papers. So one is our REDS consensus paper. crossover. So our last consensus was in 2018, and since then there have been over 170 papers about REDS. So we're going to talk about some of those findings. The fact that low carb availability has an additional effect in addition to low energy availability. We also know there's a lot of crossover between REDS and overtraining syndrome, and how do we differentiate those? We're talking more about the physiologic model. I gave you very simple pictures of a spoken wheel, but a lot of people want to know what the pathways are. What are the hormonal changes? What's affecting what? What's driving what? And then what are some of the moderating factors? We talk about our research methods. So one of the big issues we've been working on for the last 2 years in general with the WuSci Human Performance Alliance is really getting the methodology right. And so for REDS, we've written a paper talking about how do you study the hormones correctly? What's the right time? What are the best ways to do this? How do we calculate energy availability? How can we use DEXA, dual energy X-ray absorptiometry, appropriately? So we want to give people the concepts of how to do this work better, how to study women better, and then people can do this research globally. We also have a paper that's talking about the primary to tertiary prevention, so some of the treatment issues with REDS. And then our big issue, our big paper is really the REDS CAT, so this concept of doing a clinical assessment tool. So in 2015, we had a clinical assessment tool that we put together. And I'll admit, I'm one of the authors. It's not our greatest thing. Basically, we just wanted to get the concept out there and know that there is sort of a traffic light approach to it. So green light, the athlete can completely compete. Yellow light, they can train, but we need to monitor them, and we need to make sure that they're following up with their medical team. And then red light, this is scary. This person should be pulled out of sport right now so we can get them the health and medical care that they need. The reason I say is it was a little messy for us is we listed some of the things that people should really pay attention to, but we didn't give it a point system, and that's been a bit confusing for a lot of our clinicians. So how do we, for example, take into consideration an eating disorder? Does it have to be an eating disorder where they're bulimic? Is it somebody that has a really low body mass index? Is it somebody who has a really low heart rate? Is it a past history of an eating disorder? So we wanted to clarify that for people. And so when we had tried to use our own REDS CAT, I found in our clinic of 1,000 female patients, our group found that in people who were 15 to 30 years just coming into our female athlete clinic for different reasons, 96.2% of them scored between yellow and red. So imagine telling all your female athletes coming into your clinic, actually, you can't participate fully. So we needed to make some adjustments. And that's where we get our REDS clinical assessment tool version 2. And this will be coming out. And again, I know it looks busy, but we realized a lot of our athletes sort of fell in that yellow zone, and we really needed to have another zone. So we made a new traffic light. We have an orange zone now. And we have examples of what are the major indicators and what are the ones that we should really be paying attention to and what is the science behind them. We really needed data to prove that these were legit. So severe primary indicators would be things like primary amenorrhea, clinically low testosterone in males. Primary indicators would be low T3, so thyroid hormone, we can be using that as one of our markers. Low bone mineral density, falling off a growth curve. Again, these are just examples. We have others. Secondary indicators, things like high total or LDL cholesterol, bradycardia, having a cutoff for the bradycardia, knowing the differences between an athlete bradycardia and concerning bradycardia, depression. And then we have a lot of potential emerging indicators, and this is where we need all of your help because we need to be studying these to get more data behind them to add to our model. So things like decreased libido or symptomatic orthostatic hypotension or sleep disturbances. So when we tested this against the clinical expertise of a lot of different international medical providers to see where they would categorize people, it actually did really well. It had a great correlation with their clinical judgment, which we loved. And so as we move forward, the idea would be, okay, not everybody's going to be able to do all these labs on every single patient. So how do you start? How do you bring this to the athletic trainer or to the medical team physician? You might just do a big screening, a pre-participation exam, and do some surveys that are specific to your athlete population. And then if they're more than low risk, then you go to the second step. And that's where you might be doing some more blood tests and other clinical things that we can actually use to score them and then put them into a category. And then for those who are in a higher risk, then we're referring them to a clinician who knows how to manage this group of athletes and can develop a whole treatment team. So as we move forward with REDS, like I said, there's been a lot of work done in this space. There are a few people at this meeting I want you to reach out to. So Dr. Kristen Whitney is going to be talking about REDS screening and performance outcomes in Boston marathoners. But you can also ask her about the prevalence in female athletes from racial and ethnic minority groups because she did a great research project there. We have Doctor, I call her Doctor, she's my PA and she's amazing. So Meg Keating is doing a project and is presenting on using DEXA, again, dual X-ray absorptiometry, and using percent fat body comp as a predictor for menstrual function. This can help us with our recovering athletes. But you can also ask her about her RED screening at a collegiate program at UMass Lowell that she's been doing. Louise Burke, hailing from Australia, is doing a presentation about proof of concept studies in Indigenous Australian female rugby players, taking female athlete cycle into consideration. But you can ask her about her projects in low energy availability and low carb availability in endurance athletes. And finally, Ida Haikura and Trent Stellingwerf are going to talk about the REDSCAT development, how that was done. It was a huge survey around the world, and then actually specifically studying elite Canadian athletes where we could get more data on them. And then upcoming, what we need to be doing. So further REDSCAT2 testing in different populations, as well as prospective, whoops, I'm going backwards and I'm over. Wait, hold on. Prospective low energy availability and REDS intervention studies, testing potential emerging indicators and doing this prospective work. Finally, special thanks to the people on this slide, in addition to our female athlete program at Boston Children's, but these are people specifically working in this RED space, and everybody in bold here has been involved in some of these projects and is at this meeting, so you can pick their brains. And then, because I hate when female athlete topics are only given 10 minutes, we have a female athlete conference that's coming up that many people in this room will be speaking at. It's in Boston, but it's also virtual. It's in June, and there's our little box where you can see more information about it. I did it, less than 10 minutes.